Good afternoon, everybody. My name is Umberto Vattani. I'm president of Venice International University, and I would like to extend to you all a very warm welcome. It is, in fact, a warm welcome, but I would like to advise you that it's easy to reach the island, very difficult to get away from it. So do not try. You know that you are here for a 3 days experience, wonderful experience, and I would like to tell you where you are. The island of San Servolo is just 6 minutes away from St. Mark's Square. But the boat comes and goes at regular times and not upon will, so that you have really to be patient and wait for it. And I would like to say that once you are here, you forget Venice for a moment. This island looks like this from the sea, from the lagoon. And if you look at it, you only see a beautiful piece of construction. But what is interesting is what we do here. Shall we show them the next? You see different dots. Each dot represents a very prestigious university which works day off, day on here on the island together. We build and design our programs together. We carry on semester after semester. Agar Brugiavini has been for some very successful years the dean responsible for the academic programs of Venice International University. You will notice that we start off with the United States and Canada, Montreal, Duke University and Boston College. In the middle, you've got the European ones from St. Petersburg down to Munich, Bordeaux, Louvain, the Catholic University of Leuven. You have Ca' Foscari, of course, the University of Lausanne, Padua University, UAV, which is a university in Venice, teaching architecture and design. And if you go down south, you see that we have also the University of Israel, the #1 University of Israel, Tel Aviv University. On the opposite side, on the far east, you have two Chinese universities, Tsinghua and Tongji from Shanghai, and finally, Waseda from Tokyo. Now, Charles V used to say that the sun never sets on his domain. It was not really true. I mean, it was a relatively small domain. But we, in fact, can boast that the sun never sets on our network. While we work, somebody is sleeping on the other side. And when we go to bed, somebody is just rising. Well, this is simply to indicate that this has been the greatest challenge. How do you bring together professors and students from so many different countries, from so many different universities, each one coming from a department? What do you teach? You can't make dentists, you can't form or train architects. Each one has its own norm. But what we can do, we can tackle global issues together. And so sustainable growth, environmental policies, cultural heritage, all these can be carried out fruitfully together between Chinese and Russians and Americans and Germans and Swiss and Italians and Israelis. It's splendid. It's a unique place. And what we teach them is something that all scientists should attach importance to, because we feel very strongly that this type of education helps include and allow them the skill to explain what research is about. Because unless you have the gift of expression, much research can be wasted simply because people do not understand what you're talking about. And this is why people who come here, being faced with so many different nationalities and so many different backgrounds, tend to become extremely skilled in illustrating what they're doing, in explaining their views, and in defending with their own arguments. Well, this is a very valuable experience. We've been doing this for nearly 30 years, and we are lucky that the network has been increasing considerably. We look forward having in the future a university from India, one from Latin America, and one from Africa, because these three continents are not yet somehow represented here. And if some of you can help through your contacts and connections to help us get some of those prestigious universities from these places, we will be most grateful. Now, what you will be discussing today is a unique experience over 3 days, and organized by EICA. I'm so pleased that Professor Gaetano Crepaldi is here. I would like to say how pleased I am to see him, and we all are. And this progress and these items, which will be issues that you will be discussing, fall within the general umbrella of the aging program. The aging program is, again, a global issue, and one to which Agar Brugiavini has brought considerable insight. We are very grateful that this has become, in time, one of the areas which attracts people from all over the world, like you. And I'm so pleased to know that so many personalities coming from different countries meet here today. Now, the issue is aging and particularly health. And I would like to say I know very little of it, because when I was a young boy, my father used to tell me early to bed and early to rise makes a man healthy, wealthy, and wise. I do not know whether this has made me wealthy or wise. I would doubt that. But certainly it has kept me sufficiently healthy to be here and to be able to address you today. But what you are planning is something much more ambitious. And I would like really to wish you great success in your endeavors, and say how much we are grateful to Stefania Maggi and Jean-Pierre Michel for the organizational work that they've carried out. I do hope you will enjoy your stay here with us, and that at the end of these 3 days, we all at VIU will also be able to enrich ourselves through what Agar Brugiavini will tell us, and Stefania Maggi will report to us, which I think will become also a course or one of the main lectures which could fit in some of our global programs. So thank you very much for being here, and thank you for having decided to join us at San Servolo. Thank you. I think the floor now is to Professor Crepaldi.
What is EICA? I think many of you have this question. EICA is an European platform fostering interdisciplinary analysis, high-level discussion, as well as translation and dissemination of results from aging research. These results are presented to various professional groups, to policymakers, and to the general public. Aims of EICA: to build on and make use of existing European and international expertise. To put an interdisciplinary focus on questions concerning aging, health, and care. To act on a non-partisan, independent, and non-profit basis. To be open to all scientifically and politically engaged persons and institutions. how will EICA pursue its aims? EICA board member and consultant identify practice-related questions and challenges concerning aging, health, and care in Europe that are relevant for individuals, health professionals, and policymakers. Which are the main activities of EICA? To develop interdisciplinary education strategies and master courses in the field of aging and facilitate basic geriatric and gerontological knowledge among different professional figures. To release position paper and reports. To foster knowledge transfer towards the general public and layperson, and to organize interprofessional conferences for scientists, policymakers, health and care service providers, hospital operator, insurance company, medical industry, and other stakeholders such as the one we are holding now, on changing the vaccination paradigm, stressing the importance of adult vaccination. Professor Agar Brugiavini will tell you about the Rationale and the opportunity offered to EICA by the Venice International University.
So you had an introduction by Ambassador Vattani on what Venice International University is. It is a university, so it's devoted to research, but I would say dissemination of research and teaching activities. 17 universities, 11 countries, 3 continents, 1 campus, and the global, the word global is crucial because we started, as he said, 25 years ago, working on a global program. So I think we can boost to be really one of the first to worry about globalization issues. And also the spread, the geographical spread is very important because I think we are in a unique position to have feedback from all over the world, as well as to address issues which are common to all these different countries. So I don't want to make it long because you are already, we are already late, but the aging program at VIU is actually something which started together with Stefania Maggi and Jean-Pierre Michel, and we thought that we should exploit this opportunity of the Venice International University, having so many universities and centers and expertise to work on topics going from science to humanities. So we hold lectures here for students also on the meaning of aging from a literature point of view or from philosophical point of view. So we are really on a very broad spectrum. And as I said, dissemination and advanced training courses are our comparative advantage here. The benefit can really, the program can really benefit from having so many actors from so many countries because we can really learn from each other's experience and because we can contact. We have a very strong network on which we can rely and we can contact so many people. So when we say, for example, we send to an emailing list, I don't tell you the number of emails that we get into this list because, we get all the emails of all these universities. And I think this is a value which is really unique in terms of creating an entity which does rely on this exchange of experiences, exchange of knowledge. EICA at VIU is a joint effort, and although a lot of credit was given to me, in fact, the credit goes all to Professor Crepaldi and to Stefania and to Jean-Pierre, the idea is exactly to carry out several activities on different levels and use all the possibilities going from the high-level scientific meeting to the teaching to the undergraduate courses. To give you a couple of examples which are not maybe in your own specific fields, we hold every year a Summer Institute on Aging, which is the parallel that they do at RAND in the US. Is exactly the same format. We do a medical part to start with, and then we do sociology, economics to follow up. And this is becoming very popular, addressed to PhD students mostly. We have international meetings. For example, we just had one with the National Bureau of Economic Research, working on health conditions and labor supply. So it is the strength is interdisciplinarity and international experience, I would say. That's what we can rely on. I am also part of the SHARE survey that some of you may know, and so we have meetings here of the SHARE community very often, so we can rely on this. And I would say we have a privileged view on the Far East. That's something we haven't yet exploited fully, and I think we have an ideal ground here to sort of launch a bridge to the Far East in terms of knowledge transfer and training programs. So enjoy the meeting. I'm very glad you're all here, and I hope everything you need, you just ask us, and I hope you're enjoying these 3 days with us. Thank you very much.
Good afternoon, everyone. So now we all know where we are and what is the main program in this beautiful island where we're hosting this conference. And I'm going now to tell you what are we doing here and what are the main objectives of this conference. This conference has been thought long ago, about 1.5 years ago. We discussed at the WHO office, in particular with John Bird in charge of the WHO program on aging and life course, about the opportunity to devote some specific effort on organizing stakeholder meetings to address the issue of vaccination in older people. And of course, in order to do that, Jean-Pierre, Professor Michel, and myself start looking for some financial support to organize such a meeting. And I like just to start by thanking our supporters for this conference, in particular GlaxoSmithKline Biological, Merck Sharp & Dohme, Pfizer, and Takeda Pharmaceuticals, because they have provided a truly unrestricted support for us to organize this conference. So, together with the WHO program on aging and the European, the UGMS, European Union Geriatric Medicine Society, which I have the privilege to be the president in this year, and in particular with the special interest group on vaccine, so with Professor Gavazzi and Professor Fleming, we have identified the main speakers who would be speakers and participants to be gathered here today for the conference. So it took some time. It has been really a privilege and a pleasure to work in organize this conference that has a specific recognize a specific rationale. Do I have the control of the slides? Sorry. Oh, you can give it to me, I can. Thank you. So, as you might be familiar with the WHO concept of healthy aging, which is the process of developing and maintaining the functional ability that enables well-being in older age. So we are all familiar with the definition of health by WHO, which is not only the lack of diseases, but in particular for when we come to speak about older population, the main focus is about the functional ability. So any effort to enable older people to do and to be what they really consider worthwhile to do at older age. So there are several pillars that have always been identified as the main reference for the life course health promotion and disease prevention for WHO. First of all, nutrition. We know that physical activities is the other pillar, and the life course approach to both of these issues is very important. Smoking cessation. But WHO definitely, and all the scientific society, recognize vaccination as one of the pillars for promoting healthy aging. And WHO has recently organized a meeting on immunization in the elderly that was specifically focusing on which would be the main task and strategies to address the issue of vaccination in low and middle income countries. What do we have to do here is to do the same for Europe, specifically, which are the main objectives we expect to, from this conference to be suggested as strategy. So we have organized the program in such a way that we will review first the vaccine preventable diseases and the vaccine performance in the older population. We will analyze the impact of adult vaccination programs that are currently adopted in Europe, and we will try to understand the challenges of the skepticism toward vaccination in the general public, in the media, in the health practitioners, and particularly in Europe, which is the most skeptical, sorry for the mistake, of all regions when it really comes to vaccine safety. And this was suggested by, there is a program coordinated at the London School of Hygiene, and the project is called Vaccine Confidence. And for some reason, Europe has this skepticism that I think as scientists and as organization, we do have to find, and we have to find a way to overcome this skepticism. So what we expect from this conference is indeed a truly multidisciplinary, multi-step, coherent document for actions to be undertaken in order to overcome the current hesitancy and skepticism toward the vaccination in older adults in Europe, and to support the recommendations of the main scientific societies. So this is really a wish that we want to satisfy by the end of the conference on Friday. And as Professor Vattani said, we are in this island, and I can guarantee that we will not leave if we will not have satisfied this expectation from our organizers. So that is mainly the introduction to this conference, and I really wish to all of you a successful participation and also enjoy the environment. Thank you for Now let me introduce then Professor Jean-Pierre Michel. doesn't need an introduction, but just let me say that I started working with Professor Jean-Pierre Michel long ago when he was president of the European Union Geriatric Medicine Society, and he has really created the special interest group of vaccine. Useless to say that he has been one of the geriatricians with more enthusiasm and knowledge about this issue, and so that's why he has been the main organizer of this conference together. Thank you, Jean-Pierre.
Thank you, Stefania. Good afternoon. I am very glad to be in front of you today. I feel very proud because my friends are in front of me, so it's very great pleasure. You have to know that the field of vaccine was a field that I have been working on since 3 decades. And I have to say that François Denis helped me preparing my first lecture in Geneva to be professor, full professor in Geneva in 1987. So today I will speak another aspect of Geneva. I will speak about the WHO new program on healthy aging, and I was part of the experts, so I thought that I think that I will be able to give you an impression of this program. So, in fact, to do it, I will try to first tell you what are the history of the concept of healthy aging. Then I will speak about the new healthy aging definition. You know that, in fact, I put 2016, but the program was set up in 2015, but the World Assembly said that it was agreed in May 2016. So I put 2016. Then I will tell you what are the healthcare challenges and leave you with the take-home message to introduce the talk of Jane Barrett, who will follow me. So what are the problems of aging and healthy aging? When we are speaking about aging, we are speaking about a lifelong process, which is very, very important. And then when we are speaking about aging, very often we are thinking about a kind of disengagement in life, decrease in functional abilities, decrease in cognitive abilities, decreased depression. So it was very bad. And in fact, everything changed when we spoke about healthy aging. But when you are looking at any dictionary about healthy aging, the definition is the following. Healthy aging is in fact saying that you are free of illness, free of injury, and free of pain. Everything changed. And when we are looking at one population in the States, 20,000 older person over the age of 65, and you are looking at how many of them have no disease, you can say that, in fact, without any chronic disease, at least 35. If you are thinking about people without any cognitive impairment, 95. So this definition is so good, and then we move to another positive aspect, which is in fact the definition of healthy, successful aging in 1987 by Rowe and Kane. And this definition is the interplay of 3 components. The first one is in fact health, low disease and low disease-related disabilities. At the same time, you will have a high functioning and a high cognitive functioning. Then you will have a physical and social engagement. After this very successful definition of successful aging, a lot of people say, oh, it's not enough. You have to have other components. And other components are self-efficacy, productivity, spirituality, and more. But when you are looking at the same cohort of 20,000 US person, you can see that all over the age of 65, you can see that less than 5% of them correspond to the definition of successful aging, which is a problem. So after that, a lot of definitions appeared, and I will not go through all of them because they are very important, but productive aging, active aging, civic engagement, and the last one was in 2011 by the European Community, healthy active aging, which is even more difficult to reach than, in fact, successful aging. So in 2014, 2015, WHO said we have to find another definition of healthy aging. This definition was disclosed by Stefania, and in fact, I will directly pass to the past president of WHO, because yesterday we had a new WHO director, but the previous one, Margaret Chan from China, said healthy aging is more than the absence of disease. And you can see the contrast between the first definition, to be free of any disease and injury, and now healthy aging is more than just the absence of disease. And what it is what Stefania told you. It is a process of developing and maintaining functional ability that enables you to have well-being until the older age, and indeed still till death. So when we are thinking about healthy aging, there are two main components. The first one is individual, and the second one is environmental. So at the level of the individual, you have indeed genetics, you have personal characteristics, and you have also health data. And these health data are multiple, and in fact, I will not go through them, but we can call them health determinants, healthy determinants, or aging determinants. So all of us has his own or her own intrinsic capacity, which is in fact something which is personally, individually, and which is a composite of all physical and mental capacities. But we are living in one's surroundings, and these surroundings interact with our intrinsic abilities, and indeed, functional abilities is, in fact, the interplay between our intrinsic capacity and our surroundings. So if we are thinking in this way, you know that aging is a lifelong process, and life too, and you have three periods in life. One period which is to have a high and stable capacity, then a decline in this capacity, and then a significant loss of capacity. But what is the goal of the WHO definition is to try to get, when you are young, the highest functional abilities, and then to keep it as long as it is possible, to be able, when you are very old, to do what you need to do, and to do what is very important for you to do. But all this concept is based or is related to different aspects. Indeed, education. Education is fundamental, but also lifelong learning, psychological adaptation, what is called also resilience, supportive environment, access to affordable health care, and indeed, social system. And all this interplay with our aging process. So, as I told you, the main goal is now to live independent until the end of life. So when we are looking at disabilities, you can see that among the same cohort of US retired, you can see that aging without disability is about 70%. But what we have to go is to go to 90% of people living very old without disabilities. And it is the main goal of WHO. And it is a main public health goal. And indeed, we will decrease a lot the price of healthcare. Now, behind this definition, we have to indeed think about the healthcare challenges, what we have to do for this, and what the new WHO program asks us to do. If you are looking at this program, the first thing is indeed promotion of health. And when we are speaking about promotion of health, we are not speaking about one particular time or period in life, but all along your life. And what are the components of this lifelong promotion of healthy aging? It is education, high cognitive reserve, adequate and wise nutrition, moderate and regular physical exercise, no smoking, and low alcohol consumption. So in fact, when you are thinking of it, we have to think about a long life public health program and efforts. Then, if we are thinking about disease themselves, we have three categories of disease which are very important to understand. The first one are infectious disease and cancer. A few infectious diseases will kill you without being disabled. When we are thinking about Ebola, for example, they will kill you and you will not be disabled. Cancer, a few kinds of cancer can also drive you in the same way. But you have other kinds of disease, which are cardio, neuro, nephrovascular disease, or diabetes. You can die from this kind of disease, but in fact, if you don't die, you will have a long life disease, and indeed, you will be disabled once. And you have a third kind of disease, which are in fact the diseases that are geriatric disease, cognitive decline and dementia, musculoskeletal diseases, mobility disorders, and sensory impairment. They are really the main geriatric disease. They are indeed coped and by internal medicine doctors, but you have to know that more and more geriatricians are thinking that we can prevent them. You really, by acting at midlife, you can prevent most of these kind of diseases. And indeed, our impact is to push into internal medicine a gerontological perspective. And what we have to do for this is to have more and more randomized control study to show them that we are able to intervene at midlife to modify the last part of life. Then you have the start of the decrease in functional abilities and intrinsic capacities. They are also very important to say because we can prevent them. Malnutrition, I will show you in a few minutes, are very, very important and much more important than you are thinking of. Sedentary habits are not good too because these two conditions will lead to sarcopenia and indeed frailty and linked to functional decline. So another time, a gerontological perspective is very useful. Coming back to malnutrition, I would like to stress this point because it is not known, and I think that in our field of today about vaccine, we have to think of it also. Within the community, and we have about 30% of the population which is malnourished, 30%. In all the communities all over the world, we have this kind of data. When we arrive in the hospital, in Europe, about 40% of old adults are malnourished. When they are into the hospital, they lose their bed rest, they have disease, and they are much more malnourished. And in fact, survivors after an hospital stay are more malnourished than before entering into the hospital. And when they are going into a nursing home, if they lose weight, it is absolutely catastrophic. So I think that this component, malnutrition, has to be stressed again because it acts on vaccination, indeed, and it is what we call a downward spiral of malnutrition. If we are going to the last part of life, indeed, we have to speak about global geriatric assessment. And I will not too much insist on it because I know that Alberto Pilotto, who is in the room, will give a lecture devoted to this topic later. But it is the main tool of geriatrician. But what is important when we have this tool, after that, we have to think about an agreement about objective with the patient, with the family. We have to establish one managed plan, and we have to regularly review what we are doing because taking into account the results. It is what we call geriatric medicine, and I will not insist about our approach, which is at the same time physical, mental, functional, and also social, whatever the location of the old people. And in fact, geriatric medicine is, as was said by Agar before, a very nice discipline within this university because it exceeds the organ-oriented medicine, and it is one interdisciplinary approach which tries to optimize functioning and quality of life of all people. So when you are looking at the person within the community or within the hospital, we have to think also of one very important WHO concept, which is the concept of age-friendly community. And when we are speaking about health-friendly community, we are speaking about public health, and indeed, we are speaking about the outdoor space and the management of them. We are speaking about the integration of old people and handicapped people within the community. We are speaking about social participation. We are speaking about communication and indeed information. We are speaking about community support. We are speaking about housing and specifically universal design. And we are speaking about transportation, which is how one city could be more easy to live for one old adult. But we have to know also that sometime and more, we need to have long-term care. And indeed, this kind of long-term care need one humanistic approach. And in fact, long-term care are only a range of services and support coping with your personal care needs. It is that they are not specifically medical care, but more care which try to assist you in the basic activities of daily living. So we have not to forget it. All of us will die wild, but in fact, what we have to hope is to have dignified, conserving care at the end of life. And to that, you need to have a preliminary agreement of end-of-life objective and say what we need to choose as therapeutic intensity. We have 4 persisting problems. The first one is, in fact, the access to the healthcare system. The second one is the coordination of care. And the third one is the absence of political issue. And I say that because I know that the vaccine field is really concerned. So the first one is the problem of accessibility of care. And you can see the difference between the accessibility of care for the cost of care in the States. 20% of all the people cannot access to care. I think that it's better in France or in the Northern European countries. You have coordination of care, which are very important to consider too. And you can see that in Germany, the coordination of care is not so good. 40% of the care are given without any coordination, which in other countries it's better. But what is coordination of care? Coordination of care is to have frequent, timely, accurate communication, as well as problem solving, shared goals, shared knowledge, and mutual respect among the different healthcare professionals. So when you have a team, you can work as a team with a medical doctor, a nurse, physician, social worker. All of them are doing a very good quality of care, but they are working in their own field without looking at anything else. You can have an exceptional team, and all of them are working in their own way, and there is nothing to do. And with the patient, But what we need to do in geriatric medicine is to try to gather all the effort, to concentrate them on the patient, and it is really what we call the interdisciplinary teamwork. So what we need also in geriatric medicine is to have a culture of geriatric medicine and to have the help of politicians, to be able to give health-friendly health care, to have really political enterprise mind, public health prospects, administrative wish, financial support, and indeed academic defensor, geriatric team leader, training MDs, training healthcare professionals, and at that time you will be able to succeed even for vaccination and to promote vaccination. The last point, I will not say one word. I will speak 1 hour, 2 hours, or 1 day about ethical issues. They are very, very important, but it's not my topic today. But I devoted my life to teach geriatric medicine, and I think that we need more and more emphasis on the teaching of healthcare professionals, and I think that it is an urgent priority all over the world, and the impact factor of such activity will be fantastic. What are my take-home messages? So first of all, when we are thinking about the WHO 2015 or 2016 definition, we have to remember that healthy aging is more than just the absence of disease. Healthy aging is in fact the maintenance of functional abilities at the highest importance. So I think that this is a key message. So building and maintaining intrinsic capacity and living functionally independent within and our own surrounding until the end of life is really what we have to think is the best. But when we are looking at this scheme, there is big lacks. And these lacks are, in fact, we did not speak at all about vaccine in the first period of life. We did not consider at all immunosenescence. We did not speak at all about the adult vaccine hole, which are very, very important. Indeed, we don't speak at all of the vaccination for the old adult, and we forgot completely the healthcare workers. And I think that Jane Barrett will continue speaking about how we can go ahead with this kind of problem, because really, I think that within this definition of healthy aging, we missed to speak about vaccine and to integrate them as a life course project. So with that, I would like to thank you for your attention, and I'm open to any questions. Thank you. So I am very pleased to introduce Jane Barrett, who will follow me and will act in the same way that I am doing. Jane is a very well-known person who is, in fact, involved in the International Federation of Aging. She is from Canada, but she is not very often in Canada. She is everywhere in the world, and I am very pleased to have her with us today. So, Jane, you will speak about this kind of problem, lifespan immunization. So thank you so much to be with us. Thank you.
Good afternoon, distinguished speakers, ladies and gentlemen. To the organisers, thank you. It's a great honour to be with you today. And in my next lifetime, I'm going to come back as the person that drives the speedboats across the islands, because I think that's the best job, don't you? You know, just to feel the wind and see the water, it's just phenomenal. Vaccines are arguably the most important public health intervention across the life course. And so I hope today I complement my friend Jean-Pierre Michel and give life to professional experiences, but also the work of the International Federation on Aging. There's been two people already, Stefania and Jean-Pierre, that's talked about these definitions. I think the distinction that we're trying to make here is that previous definitions in 1948 and then in 1982 at the First World Assembly in Vienna, are very static in their statements about health. The distinction, and it's an important distinction that was made by WHO in 2015. And, I'll talk to you about this first. I've been in this field, working with older people and in the field of ageing for probably 4 decades now. And the one thing that causes me dismay and irritates me most is the headlines. Let me show you them. So there is a tsunami. There is a rising tide of dementia. Global population ageing, peril or promise. So those headlines denote what? I can imagine that, I'm at the bottom of the hill and you've got tens of millions, billions of older people coming up over the hill at you. It's not an enlightening image. But why do we do this? Why do we need to say this? Because it's linked to what government earnestly believe, and that is that older people costs money. True? And we can talk about the complex comorbidities, the advanced longevity, and yet the time spent in nursing homes and hostels. And yet that's far from the truth. So it was 2015 when WHO, in an article of the BMJ, at the same time as the report was launched, said older people are not a burden. And it's this definition, and I underline the word that I really want you to capture. And the same old adage as it was yesterday, ageing doesn't start at 40, 50, it starts at birth. So while we talk about here today in the next 2 days the importance of changing the paradigm in adult vaccination, really it's a life course approach. And unless we capture that story of a life course approach, then we're at risk of doing what we accuse others of, and that is segmenting the population. I put this here again because in my way of thinking, and I am the CEO or the Secretary General of an international NGO, yes, there is the intrinsic capacity, and yes, it's the environment, but it's the interplay between the intrinsic capacity and the environment that gives rise to our ability to function. And it's not about independence in my world, it's about autonomy. And autonomy can come with support from the environment, but if we ask older people to be independent, then I think we're really not talking about the heterogeneous population of older people. So let me tell you a story. This is Paul Gordon Barrett. He was born in 17th of September 1959, and he was born a healthy baby, or we thought that he was a healthy baby. At about the age of 5, my mum and dad, because this is my brother, my mum and dad took Paul down to the hospital because he was banging his head against the wall quite violently. And Mum talks about the story about the doctor coming out, and this was 1962 now, and Dr. Toffler saying there's nothing more that we can do for Paul. He has something called Eisenmenger syndrome. And Eisenmenger syndrome was because Mum, in her first trimester, came in contact with someone that had German measles. Because at that time, the vaccine for measles wasn't in Australia. And as a family, we wouldn't have been able to afford the vaccine. So Paul's life expectancy was 9 years of age. And at 45 years of age, he became the first person in Western Australia to have a heart double lung transplant. So this is Paul the weekend before he had the heart double lung transplant. Now, the story that I'm telling is not necessarily about my brother, but it's about the lifetime impact of vaccines. Not only on the individual, but on the family, on the healthcare system, on society. Because when Paul, and in the course of 7 years when Paul was alive, extraordinary, you know, the change in life. For the first time, he was actually able to wear a pair of sand shoes and walk fast. He was able to ride a bike. But most importantly, he was able to make that powerful social contribution to society. So he raised hundreds of thousands of dollars for research into lungs. Economically, it cost the government probably $1 million plus. But that life course approach to vaccines, because when he died in 2012, you know, he was 53 years of age. So it's very important that today we don't lose sight of life course approach and also at the same time as focus on adult vaccinations. Pawadi is from Afghanistan and he's 11 years of age. I'm old enough or young enough to remember the sugar cube that I had as a primary school child. And once again, my mother and father thought that was the greatest thing that we, the 5 of us, could line up for this polio vaccine. But Afghanistan is one of 2 countries in the world where it exists. So in 1952, there were 20,000 people in the United States that were permanently paralysed with polio. 1988, there were 355,000 cases throughout the world, and look, 2015, 96. But once again, it's not about the diagnosis, it's about the fact that this is preventable. So when we think about, and I listen to the scientists here over the next 2 days, let's not lose sight of the fact about the person, the contributions, the society. So I'm looking forward to scientists kind of melding into NGOs and geriatricians and gerontologists. So with the polio vaccine, 1.5 million lives have been saved. 13 million people are walking. But let's talk about something else that we might be more familiar with. And that's the impact of pneumococcal disease. And before I go further, I really want to say that one of the most important studies, I believe, that's been done in the last few years is that of NewView. You know, over 9,000 respondents over the age of 50 in 9 different European countries to understand the level of awareness around pneumococcal disease. So, what is our personal risk? If I asked those that are not infectious disease specialists what you thought was your personal risk in terms of community-acquired pneumonia, would you know it? You know, dare I say that even if I asked you to raise your hands to say, do you know your vaccine schedules, I can guarantee there'd be less than half. And that's interesting, isn't it? Because people that are interested in this field of study and committed to improving uptake rates still don't see themselves with risk. So this is from the NewView study, and the findings are very significant. You know, 16% of those that were at higher risk of pneumonia themselves, 16% at higher risk of pneumonia recognise themselves as at high risk. But just think of all those that were at risk but didn't perceive themselves at risk. I think this is more telling, and it goes back to what Jean-Pierre Michel was talking about, and that is the impact that a vaccine-preventable disease can have on function. So you can see in the brackets That's the percentage of hospitalised and without brackets non-hospitalised. And this is in a study by Vervich in 2013. Thank you. Your eyesight's are better than me. So while these are the symptoms at diagnosis, just look what happens. So if we're looking at weakness, cough, tiredness, body aches, you know, that translates into things that are functional: loss of balance, limitations in self-care, difficulty moving at home, kept from usual home duties, kept from visiting others, kept from going places. So this is the function that we've been talking about. And yet how does that impact in government policy? It doesn't, because we haven't got to that stage in actually talking with policymakers about vaccine preventable diseases in the context of function. So I then take this loss of balance notion and then extrapolate it and look at the impact that it has. So 20 to 30% of 65s and over, loss of balance. 424,000 die from falls. $37.3 million in medical attention. 17 million dailies lost, and 120 million savings if the falls were prevented. So you can see that there is a domino effect. I now just want to touch on, you know, the at-risk groups, and I understand that we have specialists that will be talking about this, you know, during the course of the next 2 days. You know, but clearly, you know, complex comorbidities increase the risk of pneumonia, which then increases the risk of hospitalisation, therefore increases the risk of not returning home. So it's the domino effect once again. And I'm just going to touch on shingles and acknowledge Dr. Johnson. Is Dr. Johnson here? Thank you, sir. Your articles were very helpful, so I look forward to talking with you afterwards. So my point here is that in my reading, you know, up to 1 in 4 people over the age of 65, you know, will contract shingles. And the incidence increases with age. But most importantly, and that's why I'm going to call on you, Dr. Johnson, tomorrow, is post-hepatic neuralgia and the impact on that on function. I was also asked to talk about reablement. You know, what's the issue around vaccine preventable diseases? What's the relationship? Is anybody hot in here? Is anybody hot? It's hot, isn't it? Give me 5 or 6 minutes and then you can go and get some fresh air. I feel people sort of wilting with the heat. Yeah, okay. So, you know, reablement really is a notion about being proactive in terms of maintaining and sustaining functional ability. And as we've talked about, the trajectories, you know, that we believe that an older person could go through. Dr. Michelle, Professor Michelle has gone through these quite extensively. I think when I'm looking at this, my question to you, is there a time in the latter stage of one's life that vaccines wouldn't be recognised as a public health intervention? And I think it's a question that needs to be asked, and it's a question that needs to be answered, because with fiscal constraints in the public health expenditure, you know, I can see that there will be a time when, as at a WHO meeting several weeks ago, the question was, well, can we just stop all vaccines at 85? And I think my response then was, I think that's called age discrimination. So, in closing, I believe that what we need to be doing is certainly having meetings such as this, but also taking the talk into action. And the action needs to be at a national level. You know, because nationally there are specific and unique barriers that need to be addressed. But they can't be addressed with 1 or 2 stakeholders. You know, we need the scientists as well as civil society, academics, and policymakers. I also have a strong belief that we need industry at the table, so I'm delighted that industry are with us today and over the course of the next 2 days, and will be certainly making presentations. It's vital, because industry is just as a greater influence as academia, because they bring intelligence to the table that we don't know. And so I really encourage us to see industry as part of the stakeholder group that actually changes policy. So this is an example of looking at the potential barriers, looking at the environment, and then in Spain, trying to highlight which of the barriers are almost impenetrable, which ones that we can actually make change with. And it's this level of detail, and in more detail, that's required at a national level. So, 4 key messages. Vaccine-preventable diseases are one of the leading causes of morbidity and mortality in older adults. At-risk groups are more likely to be hospitalised, and therefore the cascading effect. Decreasing functional ability, increasing services required in them. And then also you've also got the children who are the caretakers. Thirdly, just want to stay on this point for a minute. I maintain, and Canada is a good example, and my colleague from Canada, we really have, a very strong public health message around particularly flu vaccines. But my point is that it's not good enough to say it's flu vaccines, go and get your flu shot. That's not working anymore. We actually have to understand what is the message that catalyses us into action to go and get the vaccine. It may be that there are barriers that prevent us from getting the vaccine. We may have to go to the doctor, then to the pharmacist, then back to the doctor. But if the messages are not being heard in a way that triggers our action, then we actually need to go back to that point. The second is the pipeline for messages. In a world of social media, should we be paying more attention to social media as a pipeline? Have we actually measured the impact of different pipelines and uptake of messages around adult vaccinations? We haven't. So we need to actually have a body of work that looks at, behavioural economics around adult vaccines. So the message and the messenger are critical. And finally, the IFA, that's the organisation I represent here today, is committed to improving the uptake rates of adult vaccination. And the reason for that is we believe it's a win-win for all. Because if we want to be healthy older adults and contribute socially and economically, then we actually have to look at this from a life course perspective. If we told a grandmother that unless she was vaccinated, flu, pneumococcal, she wouldn't be able to take care of her grandchildren, that may be the message that triggers an action. So we need to think quite differently. I'm inspired by the title of this conference, stressing, changing paradigms. But my question to you is, who are we stressing it to? Ourselves, policymakers, the target audience, academia? And at the end of the next 3 days, I think it would be helpful to go back and ask ourselves, who have we stressed this message to around the changing paradigms? I thank you for the opportunity of sharing some information and my stories with you today.